Good morning. I'm Natalie Callander from the University of Wisconsin. I have a little bit of shield hair here. I've just been rounding on our transplant ward. So I'm going to talk to you a little bit today, and I'm going to try to share my screen. So what I'm going to do today, and here's the outline of my talk, is basically talk a little tiny bit about myeloma epidemiology, because we're all here together as people interested or either having myeloma or caring for somebody with myeloma. Talk a little bit about that. Why do we do autologous stem cell transplants at all for myeloma? And then the question that I think comes up is, should everybody get a transplant? And also, what are some of the results with autologous stem cell transplantation? And then I think a very pertinent question, are we always going to do transplants? So I think, unfortunately, I think there was some controversy earlier or some years ago about whether or not myeloma is becoming more common. And I think most people think it probably is. So these are the most recent data from the American Cancer Society showing that the incidence of myeloma in both men and women continues to be increasing. And we think it's not just a phenomenon of more cases being discovered because we're just better at diagnosing it. As I think everyone here in the audience knows, there are still unexplained differences in different types of populations for the incidence of myeloma, with a lower rate seen in people of Asian descent, and of course the highest rate, at least in the US, seen in Black Americans. And again, this is also unfortunately true, carries over to death rates as well. This is an interesting map that was published this year looking at incidence of myeloma by state. And you can see that there are some areas shown in the brown that seem to have a higher incidence of myeloma. And again, that may reflect some of the ethnicities of the populations who live there. So to clarify terminology just for the rest of the day, an autologous stem cell transplant or an autologous bone marrow transplant refers to using your own cells. And basically, and I think sometimes there's some confusion about this, what we're doing with those cells is they're really sort of serving as an antidote for what we call the conditioning regimen, which is basically chemotherapy or chemotherapy plus radiation that's used to kill off any remaining cancer cells. And the bone marrow or cells that are infused in are basically there to help your blood counts recover. And that's opposed to an allogeneic transplant, where we're often still giving conditioning regimen to control the cancer, but at the same time, those cells that we're giving, or marrow, it can be that as well, are actually supposed to be fighting the cancer itself through some immune effects. And for reasons that I'll just touch upon later, allogeneic transplants are done very infrequently in multiple myeloma, and really, I think, are considered by most experts to be a research question. So why do we do autologous transplants in the first place in myeloma? And I think to frame this is a nice map. This was actually published in Circulation recently, looking at the development of various drugs for the treatment of myeloma. And I'd like you to focus here on this area, going back to the 1960s. So the average survival for a person diagnosed with myeloma in 1960 was 6 months, which is obviously terrible. And right at the end of that decade, simultaneously in the Soviet Union and the United Kingdom, melphalan, or L-phenylalanine mustard, was developed as an oral agent and was given with steroids. And this increased survival in myeloma from 6 months to 18 months, which was really a big deal. But what then happened, if you look at this timeline here, that nothing is happening. In other words, 25 years go by and there really isn't any improvement at all in myeloma treatment, and really not many drugs. So it's not surprising, therefore, and that's listed on the timeline here in 1983, a couple of investigators in the UK, McElwine and Powles, basically said, all right, we've got one drug here, we've got melphalan, why don't we do something different with the melphalan? And what they ended up doing is treating 9 people, some with newly diagnosed, but others with relapsed myeloma, with one big slug of intravenous melphalan. And what they ended up publishing here was that something quite surprising that had really not been seen before, that of these 9 patients, 5 of them responded, so very high response rate, and 3 of them appeared to go in remission. It was really something that had never been seen before. But what they did notice is that the time that these individuals had very low blood counts was for weeks. And so, of course, the idea was, all right, there's dose intensity that seems to be helpful in myeloma, but we're going to have to do something to help people improve their counts. And so this started to be explored in the mid 1980s. This was a paper published 40 years ago by Bart Barloghi. And what they did in this particular study is take people with myeloma, just a handful, and actually do an autologous transplant. In this case, they were treated with melphalan, and then they were able to show that they seemed to do a little bit better than not doing a transplant, but it was still the takeaway message was maybe if you wait too long when a person's had myeloma for a while, the transplant doesn't do much. So fast forward another 10 years, and this is really the study, I think, that sort of broke open transplants for myeloma as we know them today. And this was a study of 200 newly diagnosed patients with multiple myeloma from France. And they received either the best chemotherapy of the day, a combination called VCMPB, which we don't use anymore, but they either got that chemotherapy or that chemo plus a transplant. And what the investigators showed was really striking because the response rate was way higher, but also in long-term follow-up, the survival rate was literally almost 5 times better if a person had a transplant. And one of the other things that they noted in a follow-up study is that the quality of life for people after they recovered from the transplant also seemed to be improving. So right now, autologous stem cell transplant for multiple myeloma is really the #1 indication in the US for a transplant. And we're going to talk the reasons why. And many of us think that this number should actually be twice as high as it is, because we really do think that there are measurable benefits from a transplant. So to talk a little bit about how we sequence in a transplant or make this decision, as many of you know, if you're newly diagnosed with multiple myeloma, the first thing we decide to do is how are we going to treat you initially? Now, we never do a transplant as the first step, so we always want to give a lead-in type of chemotherapy. So how we pick that is also undergoing changes right now. And as opposed to the 1960s, where the response rates were quite slow with drugs like melphalan, we now know that we can use combinations that can give very quick response rates, often in a month or two. And we want to do that. We want to get that deep response. We want to improve the performance status. That means how well somebody's functioning just in their daily role. And we want to improve their quality of life. Of course, we want to limit side effects, but we also want to pick drugs that we think can help not interfere with stem cell mobilization. And currently, most of the research is looking at, should we offer you 4 drugs or 3 drugs, or maybe for less fit individuals, 2 drugs? And then how long are we going to do that for? And then finally, if we're going to offer a transplant, when should we do that? And by and large, and I'm not going to touch upon this right now, most of the transplants done in the US are done as part of initial therapy, as part of an initial package of treatment. Now, one of the things to keep in mind is that if you look at the average age of a person diagnosed with myeloma, it's 69, and more than a quarter of people diagnosed with myeloma are over 75. So for a while, it seemed like transplants were only something to consider in younger patients, which was really initially defined years ago as less than 60. But more and more, we believe that the thing that we should be paying attention to is actually fitness. Now, this is not a transplant study, but what I'd like to focus on here is in the blue line are patients who are older, but who are considered fit. So they can do all of their normal activities, they can manage their money, they can handle transportation, whether that's driving or getting on a bus. And if you look at people who can do that, regardless of their stage of myeloma, they are going to live longer than frail individuals. And they're also going to be more likely to adhere to treatment. So we do now, when we're recommending autologous stem cell transplant, really look at fitness as a very important factor. And there are people who are 50 years old who probably shouldn't get a transplant because they have too many other important medical problems that might cause some interference. Now, very quickly, I know the other speakers are going to touch upon this. Most of the time, you are going to be offered a stem cell collection if you are opting for treatment for a transplant after about 2 cycles of therapy. You can do this later on there's various reasons why that sometimes it gets a little bit more difficult. And typically, you're going to receive what's called mobilization. Now, more and more, this is done with 1 or 2 drugs, either just growth factor, something called granulocyte colony stimulating factor by itself, or often now with a drug called plerixafor or mobazole. And then there are still some people who are receiving chemotherapy as part of their mobilization strategy. And then anywhere from a few days later to several weeks later, if it involves chemotherapy, you're asked to come to get cells collected with an apheresis machine that's shown over here. And either you'll have this done either through peripheral IVs, or sometimes a central line will be placed, and then your blood will be filtered to take out these stem cells. And typically per transplant, we're looking for a minimum of 2 million cells per kilogram of body weight. And most transplant centers are looking to collect a minimum of 5, so that there could be enough for 2 transplants, either done at the same time, back to back, or later on as a salvage therapy. So this is very briefly, again, the time course of what to expect if you were having a transplant. And so this is showing a person, getting that mobilization, which bumps up their white count. The cells are collected down here. Then they're coming in either the clinic. In many places do this completely as an outpatient, or some people are admitted, getting this melphalan, which has been really over the years compared to many, many other drugs and still seems to be the winner in most studies. The melphalan is infused, and then you are either monitored or as an outpatient or followed for in the hospital, usually about 2 weeks for the very severest side effects. Usually can be some nausea, vomiting, diarrhea. You're given a cocktail of antibacterial, antifungal, antiviral medications. And then in about 2 weeks, your counts recover and you're either at home or you're sent home. And in reality, it takes several more months after that for people to feel like they're back doing most of their normal activities. And it takes about 60 days to see somebody's hair regrow. Okay, so if we can give you kind of a laundry list of what are the pros and cons of autologous stem cell transplantation, I think definitely in terms of advantages, and many of us who've treated patients still believe this, is that one-time therapy, yes, you are making, this is a project to do this. This is several months in the making, but it has a lot of advantages in terms of being over with. And so instead of coming in weekly for repetitive cycles of chemotherapy, we can say, let's focus on getting this done, and then you get back to living. There is a track record of effectiveness of this intervention that I'll show you shortly. You can do this twice, which is wonderful, or some people have had even 3 transplants. And then even adding in another piece to this package, the induction, the transplant, and now maintenance, we really hope that in the majority of people, we can control their myeloma for years before they're even going to need to consider another intervention. On the disadvantage side, clearly there are side effects, as I mentioned during that little schema. And there's also a death rate that's measurable. It's less than 1% in most transplant centers in the country, but it is still there and it is a risk, and which is one of the reasons we look at that frailty equation. There is the confinement in the hospital or clinic, and of course you've got time away from home and family and work. And then there are rarely some long-term side effects that are associated with transplant, probably the most serious of which can be blood disorders related to the transplant and potentially maintenance that happens maybe 1 to 2% of patients. That can really be life-threatening. But let's move on again to the results and why we keep recommending transplants. So you saw the results from almost 25 years ago. What about more recent results? And so this is a study from Italy where they compared transplantation to the combination of melphalan, Revlimid, and dexamethasone. And as you can see in the blue lines, the patients who got transplant, and particularly maintenance, ended up having a much better control of their myeloma. And actually compared to those patients getting oral chemotherapy and no maintenance, the survival was enhanced by the transplant. Here's another study from Europe where instead of melphalan, prednisone, and Revlimid, they gave oral cyclophosphamide, Revlimid, and dexamethasone, and compared that to a transplant. And again, you see the same type of results where patients receiving the transplant had better control of their myeloma, but they also have better survival as well. Now, studies like these have been criticized, saying, well, that's not the chemotherapy that we give in the US, so of course it didn't do as well as transplants. So what if you gave what is considered right now really the gold standard? And that brings us to the IFM 2009 Dana-Farber Cancer Institute study, in which a large number of newly diagnosed myeloma patients less than 65 were randomized to receive, again, best chemo that we believe, Velcade, Revlimid, and dexamethasone, either that as chemo alone for 8 cycles or that chemotherapy with a stem cell transplant followed by VRD for 2 more cycles and then a year of lenalidomide maintenance. And what this study has showed, and it continues to be reported upon, is that significant difference in control of myeloma, what we call progression-free survival. No particular difference right now in overall survival, but a lot of people think that's related to the fact that by design, people in the chemo-only arm were salvaged with an autologous stem cell transplant if they progressed. There also does seem to be an advantage if you were looking at MRD, as we call it, minimal residual disease, for the transplant arm. So this study is still being analyzed from the US component, and we'll be very interested to see if this is that data holds up as well. And that'll probably come out, I believe, sometime next year. How about 2 transplants? So this is a study that was recently updated again from Europe, where patients with newly diagnosed myeloma received Velcade, cyclophosphamide, and dexamethasone, or CyBorD, and then they were randomized to receive Velcade, melphalan, and prednisone, or a single or double transplant, and that was assigned based on what those transplant centers normally do. And then they were randomized again to receive more consolidation with VRD or no consolidation at all. So what I want to focus on here is basically what happened after that second transplant. So does the data support doing 2? So they did show that a number of patients had a significant improvement in their response after the second transplant, and particularly people with high-risk myeloma were teased out, and they did look like they benefited from that second autologous transplant. What should be kept in mind is there were some patients who actually didn't look like they responded to that second transplant. And then one of the other criticisms of this study of recommending autologous stem cell transplant for everyone is that the induction was not Velcade, Revlimid, and dexamethasone, and some people think that makes a really big difference. So that brings us to actually Dr. Gerald's study, the Stamina trial. This is a US trial where patients could have any kind of induction for up to 12 months and then had a stem cell transplant and then one of 3 types of maintenance or consolidation. And a third of these patients were randomized to 2 transplants. 1/3 had VRD consolidation for 4 cycles, and the other just went straight on to lenalidomide maintenance. And what this study has reported out and shown is that if you look at the entire groups based on intent to treat, that means everybody gets assigned to their group and you analyze it that way, there didn't appear to be any advantage for any of these treatments over lenalidomide maintenance with a stem cell transplant in terms of both progression-free survival and overall survival. And also, there seemed to be no difference in the arms in terms of what we call secondary malignancies. Now, more recently, there has been an attempt to say, okay, if you look at high-risk myeloma, were there any differences seen between these interventions? And at least it looked like on a raw numbers based on that intent to treat basis, no. However, if you break it down to look at, particularly in the second auto transplant, the double autologous stem cell transplant, it does appear that people who got that second transplant, particularly if they had higher risk disease, may have benefited from that. And so that is something that I think is going to be focused upon. But again, statistically, it's a little bit squishy to say, you know, only look at people who got the treatment. Usually we believe it's more important to look at the whole group. One of the other factors that came out from this longer term analysis was that still that lengthier time on lenalidomide maintenance seems to be helpful. Now let's go quickly to allogeneic transplant here. And I mentioned that there really hasn't been a lot of data that supports the routine use of an allogeneic transplant for myeloma as opposed to other blood disorders. And this is very long-term data just published by Dr. Geralsh this year, looking at a study that compared a large number of patients who were randomized to receive either tandem autologous stem cell transplants or an autologous transplant followed by a low intensity allogeneic transplant. And even after 10 years of follow-up, if you look at these graphs, they still were unable to show an advantage for an allogeneic transplant. There was a suggestion that in high-risk patients it might be better, but this is not considered statistically significant. So in my opinion, allogeneic transplants, why they continue to be very tantalizing as perhaps offering a cure, are still something that are largely a research question and something that we hope that we continue to try to craft studies that can answer that question more effectively. So how about, will transplants become obsolete? And this is something called the Forte trial, looking at what was considered best chemotherapy. These are all carfilzomib-based treatments. Again, I won't go into all the details, but the idea here is if you give people enough carfilzomib based regimens, like essentially a year of therapy, could you just stamp out the transplant? And so in terms of things like progression-free survival, they were able to show that they were equivalent in terms of looking at the responses to a year of carfilzomib, Revlimid, and dexamethasone versus some months of that with a stem cell transplant. But one thing that does appear to be different is obtaining minimal residual disease. So here in the orange, people receiving the transplant look to have a higher rate of MRD negativity in those who could be evaluated for it. And one of the other factors that was found is the patients who had an autologous transplant had a lower rate of early relapse. So everybody is looking forward to seeing whether or not this holds out. But I think, in my opinion, this still shows that there is benefit for an autologous stem cell transplant. So are we going to be doing stem cell transplants 20 years from now? And I think really the big challenger is going to be the immunotherapies. And this is just a slide to remind everybody, if you look at only one target that is under investigation in myeloma, B-cell maturation antigen, there's all sorts of ways to exploit this. And if we just look briefly at CAR T, so there's drug antibody conjugates, there's bispecific engagers, but just looking at CAR T responses, very high responses in a very heavily pretreated myeloma population. So the question's out there, if we start moving a CAR T transplant maybe to frontline therapy, is this going to essentially knock myeloma off the pedestal? So I think we're very interested to see what the results of trials like this that are coming out soon are going to show us. So that is the end of my talk. And in conclusion, I think autologous stem cell transplants really are a very important part of myeloma treatment. They do offer excellent control of myeloma. It does offer time off of more intensive therapies and time away from the clinic. I think in many cases, people do come back and say, you know, my quality of life in the short run was harder, but in the long run is better. Even transplants still remain important with the best drugs that we have. It is possible, however, that newer therapies in the future are going to dethrone transplantation. So thank you very much.